Voy a presentar a la siguiente.
Introduce the next speaker, who is Lourdes Durango. Lourdes Durango is a nurse and specialist in natural fertility awareness. She has been from 2001 collaborating in natural fertility awareness in the Salvia Clinic. Since 2017, she works in the CUN headquarters in Madrid, expert in natural assessment of the fertility, and she works with Dr. Chiva in the gynecology department of that hospital in Madrid. She's expert in the analysis of the cervical secretion and in the ultrasound follow-up, and I'm aware that she does an excellent work. You have the floor. Thank you very much, Mika. Thank you, all the organizers as well, for inviting me to be here and for trusting me. The talk I have to give today is the Symptothermal Method, integrating vision of the fertility indicators. It's hard to say anything new right now because after the 3 days and after Dr. Ruiz Zambrana has done in his key lecture, what can I say after what he has just said? But I'm going to try to make a sort of summary of what the symptothermal method means, that gathers all the indicators that we've seen throughout the Congress. But I would like to start by making a small history where we can see the origin and the evolution of the symptothermal method that we know now, how they have added and integrated the different indicators of fertility. In 1905, the gynecologist van den Velde discovered the existence of biphasal curve in the cycle of the woman. In 1927, there was a correlation hypothesis of those changes with ovulation. From 1930, von Hildebrand showed the couples in his parish to have graphs where they collected the daily temperature to distance the pregnancies. He was the first professor of family planning, natural family planning. In the 30s, two gynecologists from different countries, Japan, Dr. Ogino, and Austria, Dr. Knaus, reached a conclusion that in the cycle, the determining fact was ovulation that takes place between 12 and 16 days before menstruation. In 1947, Vollmann published the first rules of interpreting the temperature curve. And that year, they also published for the first time the data about its efficacy. In 1950, the doctors Rötzer and Breau pay attention to the cervical mucus, the basal temperature, and other signs of fertility, publishing for the first time a symptothermal method to delimit the phases, the sterile and not sterile phases of the cycle. In 1953, Dr. Billings, apart from whatever has told us, that data I didn't know, and it's quite striking. After 2 years of study of couples that got pregnant using a natural method in order to prevent it, they observed that most of the women had noticed more flow around the external genitalia around the day where they supposed that it was the fertilizing relation day, and this encouraged them to keep on studying that secretion. In 1954, Göring structured the first method of the temperature that was then known to the German-speaking population. And further on, Kiev is adding the indicator of cervical self-palpation. In 1964, Geller and Rötzer prepared a standardized method for gynecologists in order to determine the ovulation as a method for regulating the fertility. They published Temperature Guide for Women that was translated to many languages. Professor Odeblad, after 10 years of studying the cervical mucus, classified the types of mucus in E. estrogenic and G. gestagenic. After the years, this classification was more enriched with other types of cervical secretion. By means of ultrasound studies recently from Freund and Flynn, they confirmed the precision of the symptothermal method to indicate the ovulation. The practical efficacy of that method varies between 97.6% and 99.6%. And this is justified by the simultaneous use of several parameters, what we call the double check. This can make that its use is somewhat more complex, but it improves the efficacy and gives a greater security to those who use it. Since more than 20 years, the study of subfertile couples that wanted to conceive was started with the central-based temperature and the consequent following observation of if the graphic was biphasic or not, to see if there was an ovulation or not. And the Symptothermal Method was incorporated in 2006 in the Protocol of Contraception of the Spanish Society of Gynecology and Obstetrics. And what are those indicators that are all integrated in the Symptothermal registry? We have the biological indicators, 3, the TBC, mucus patterns, what they see and they feel, the secretion they have in the vulva, we've seen that several times, and the changes in the cervix. Within the major indicators of fertility, we also have the statistical indicators. These are the modified Ogino calculation and the Durango calculation. And then there is another series of minor indicators of ovulation that are minor because they don't happen in all women, and in whom they happen, they don't feel it in all cycles. This is documented by the World Health Organization for controlling birth rate. And what is the key of the Symptothermal method? In order to determine where it starts, where the fertility window starts and ends, they do the double check, using at least 2 indicators major for that, both for the beginning and for the end of the fertile phase. The cervical secretion, I'm not going to dwell. We have talked about the mucus all those days. The woman wants of the things that they have to write down are those changes that she observes in the mucus pattern, what she sees and what she feels. In the pre-ovulatory phase, as we're going to determine, is the beginning of the fertility window. In the Symptothermal method, the onset of any type of cervical lubrication or secretion is indicating the beginning of the cervical screening. Also, the CMO is also During also is used. The length of the shorter cycle -20. This modified Ogino calculation can be also used. We can also use the During calculation. What it collects is the important thing to know where the fertility is, not the length of the cycle, but when the ovulation takes place. And for that, it takes the temperature indicator, the earliest high temperature, and we subtract 8. And with that, we have the last infertile day before the ovulation. In the double check that we do, we pay attention to the earliest one between the cervical secretion and the calculation. The day that is before, that's the beginning of the fertility window. In the post-ovulatory phase, what we do is determine the end of the fertility window, detecting the peak day, as they say in Chile. The peak day is the last day of secretion of fertile type and or lubrication. This day will detect it the next day when we stop having fertile mucus and we stop having lubrication. That peak day tells us that the ovulation probably has taken place that day or even 2 days before or 2 days later after that peak day. We will do the double check in this case in the second phase with verifying the increase of the temperature. And the end of the fertility window will be the 3rd day of the latest symptom between the cervical secretion and temperature. And how do we know that temperature has risen? Well, we have already explained in the workshop, Dr. Ruiz Zambrana has explained as well, that the temperature goes up after ovulation due to the effect of progesterone. We already said that we can use any type of thermometers in principle, well, gallium, digital, but as long as a series of conditions are met. Although we mentioned them already in the workshop of fertility indicators, I think it's important because how to take the temperature is not valid. All are not valid. Temperature has to be taken in baseline situation before getting up in the morning, after absolute rest of 2 hours before taking the temperature, measuring the temperature every day at the same hour, also during weekend. Then when we know the chart well, Not all the days of the cycle will it be necessary to measure the temperature, only the most important ones. It has to be central, be in contact with the mucosa. We can't take it under the arm, axillary. It has to be under the tongue, vaginally or rectally. If the temperature is taken orally, the thermometer has to be 5 minutes in contact with the mucosa before looking at the temperature. If it's vaginal or rectal, with 3 minutes will be enough. And it's important to write down any change in the routine that could affect the temperature. We said that already. Big dinner, not enough rest, a few drinks at night, etc. And how do we know that the temperature has risen? How can we say that the temperature increase corresponds to ovulation? There are rules that accrue the rule 3 that the increase of temperature has to take place when 3 consecutive values happen, all of them greater than the 6 previous. 3 temperatures over the 6 previous ones. And we can see the example there. We write down a line of reference between the high and low temperatures. That's the baseline level given by the greatest value of the low values. This line represents the level of low temperatures. So it separates the low temperatures from the high ones. And in order to meet those rules, well, the third day of temperature has to be located 2/10ths of temperature over the high line. And that's how we determine the beginning of the end of the fertile phase. There are some exceptions to this rule that require more explanation, and I'm not going into details because we don't have enough time for that. What is baseline temperature giving us? Well, on the one hand, the thermal increase confirms that the cycle has been ovulatory. If the temperature doesn't go up, we haven't ovulated. We are in an anovulatory cycle. This is important to know because in those charts that we were shown this afternoon by Dr. Manuel Donoso, in which we have those mucus patches where we have the mucus, it disappears and appears again. If we take the temperature as well, when the first patch of mucus, the temperature has not gone up, so there has not been any ovulation. We have to wait for it to happen later on, or maybe it doesn't happen. So we have that doubt if we have ovulated twice because the temperature didn't get up. We ovulate only when the temperature goes up. It doesn't tell us that we are going to ovulate, as happens with the cervical mucus, but that we have already ovulated. The duration in the profile of the plateau tell us as well about the quality of the luteal body. Between the 5th and 7th day after the ovulation, we reach the maximum level of progesterone. So these are the indicated days for a hormonal study, at least if we want to do it specifically. In Creighton, they do the assessment for several days, but we also, the temperature is telling us about how this phase is. This is extremely important in cases like, for instance, when we meet women who have late ovulations. If we make a protocol and we take the temperature, do the analysis of progesterone in the day 21 as a protocol, and as that woman, the ovulation takes place much later, this can lead us be misleading. She's not ovulating or something is happening. But if we are guided by the temperature, we know what is the adequate day to do this assessment of the progesterone. What else is baseline temperature giving us? It also tells us when to start a treatment with gestogens. When we find that luteal insufficiency, we have found very often cases of women who have been diagnosed of a luteal insufficiency, and then the gynecologist, as she wants to get pregnant, well, you have to take progesterone and take it from day 13 to 26 of the cycle. She comes to the office. Well, first, when do you ovulate? Because we have a very recent case of a woman. The first chart, we find that the temperature goes up on day 17. What happens if the progesterone is taken from day 13? We inhibit that ovulation, 2 minutes left, so the woman is not going to get pregnant. So it's important in order to support this treatment. Duration superior to 16 days, normally diagnosis gestation. Duration under 10 days is a diagnosis of luteal insufficiency. In some cases, it can help to the diagnosis of hypothyroidism. We have an example in a chart of gestation where the temperature is maintained elevated beyond 16 days, and at the end we have a positive pregnancy test. And this is an example of a luteal insufficiency where the temperature rises, meets the rules, but it falls before the 10 days, and she has her menstruation, and we have thus this insufficiency of the luteal body. Another major indicator that we also can use, but that is called the third biological indicator, is just a support to the two others, especially in situations that are more complex as as menopause or breastfeeding. Premenopause, lactation, where some indicators do not give us so much information, the cervical secretion decreases. So we need a support that can be this cervical self-palpation. These changes in the cervix, well, since 1930, there were different researchers as Calkins, Cox, Dutton, Garrett, and Bishop that tried to identify factors that could predict the duration of the labor and that are also helpful to determine the elective induction of the delivery. The triggering of the delivery is due to an increase of estrogens. It's the same cause that in the cycle is causing the cervical changes. What are the parameters that we are going to be able to determine? The opening, the hardness, the height, and the slope, or the inclination. I like to do that with their hands. I think it's visual. We have the left hand is the vagina. My hand is the right hand is the uterus. With the tip of my finger is the cervix. When she's infertile, this is closed, it's hard, and this is close to the vulva. When the woman is fertile, due to the effect of estrogens, this is straight, goes up, is opened, and becomes softened, favoring mechanically the contact and the rapid ascent of the sperms when the woman is fertile. We can see that the changes in the cervix happen gradually pre-ovulatory, and after the ovulation, we have a sudden change. This is the regency, how it goes up, becomes straight, and after the ovulation, this comes back again to the beginning. You have to come to an end. We have to learn how to recognize those changes. It's important to do self-palpation throughout the whole cycle until the woman knows how it is once the menstruation is finished. And finally, the minor indicators that we have said not always happen. And this is headache, abdominal distension, intermenstrual pain, acne, sensibility in the breast, changes in the mood states, variations in the libido, and what Dr. Rizambrana said, we can incorporate as other indicators that can be a support for us, that the LH strips and hormones as progesterone and estrogens, that right now there are sometimes they fail, but sometimes we can open a field for research to see how they can be correlated in a better manner. And this is a chart of symptothermal chart where we can see the fertility window with all these rules and the double check. The blue part is the fertility window. The cervical mucus starts on day 10, but according to Döring's calculation, it starts on day 8 is the last day of infertility. And the second part, we do the double check with temperature and with the end of the cervical secretion. And the third day shows us what is the end of the fertile phase. Thank you very much.